Good evening, everyone. Thank you for staying. It was a challenging case, so I hope everyone are still on their toes. We have an exciting session, which in the genesis of atrioventricular valve. We're going to have two cases, and I'm more than happy to welcome our panelists, Dr. Ahmed Al-Salik, Dr. Eberhard Group, and Fahad Makhdoom, and Dr. Faisal Al-Goufi, and Dr. Zakaria bin Musa, and of course, last but not least, Dr. Anas Mirdad, our procedural analysis. So we're going to start with our first talk, which is going to be run by Dr. Ali. Please, Dr. Ali, if you can come to the... Where are we? Do we have Dr. Ali in the room? Dr. Ali? So, Dr. Fahad Makhdoom, if you may introduce Dr. Ali.
Welcome everyone to the session. We'll have Dr. Ali, who's gonna interventional cardiology consultant from Jabir Hospital in Kuwait. I had the pleasure to visit them in the center where I was introduced to Dr. Ali. He's gonna present to us advances in transcatheter mitral valve replacement. Dr. Ali?
Okay, Dr. Ali, you can start.
Well, thanks for having me today. Thank you for allowing me to present this very interesting topic on transcatheter mitral valve replacement using the SAPIEN M3 valve. This will be very clinically relevant as we just heard about CE mark approval of this system being the first transcatheter mitral valve system to be approved for the mitral position. In fact, this is one of the cases that I was blessed and honored to have some involvement with the team in Vancouver, led by Dr. John Webb. This is one of the first transcatheter mitral valve replacement done back in 2018, even before the ENCIRCLE trial. So that was under a special access program. So starting with the case, this is back in 2018 when a 77-year-old lady presented with exertional shortness of breath in keeping with NYH class 3 symptoms. You can see on the transesophageal echocardiogram she has severe mitral regurgitation with mildly decreased LV systolic function. Her ejection fraction was calculated at 40%. With regards to the etiology of MR, it was thought to be mixed in etiology, primarily driven by functional dilatation of the atria and ventricles, but also has a component of anterior leaflet prolapse. The patient was worked up for TEER as well as TMVR at the time, with a CT scan showing low risk for neo-LVT obstruction. The patient was also discussed at the heart team rounds, and the decision was thought to be better for TMVR given borderline anatomy for edge-to-edge repair. There was posterior leaflet calcification, and surgery was thought to be high risk given this STS risk score of 10%. So this is just an animation of TMVR using the SAPIEN M3 valve. It's a transvenous transseptal puncture going with this system, and the tricky part is deploying the dock. The dock is deployed under GA, under TE guidance. The key is to deploy the dock towards the medial commissure, and that dock will work as an anchor for your valve. So after deploying the dock, it's a pretty much straightforward mitral valve in a ring or mitral valve in valve procedure. I'm not really going to spend a lot of time talking about the technicality of this procedure because I think we have the panelist discussion and we'll go over.
So we will hold here. This is an interactive session, so feel free to approach the mic at any time you need. So I'm going to start with Dr. Zakaria. I mean, seeing the previous images, do you think edge-to-edge repair in this case was a feasible option or TMVR? Mind you, this was in the beginning of 2018.
So I noticed there is a lot of calcification, especially in the posterior mitral annulus, and in the presence of the MAC, I would hesitate to go for TEER. Additionally, in 2018, at that time, the experience with the dealing with such a valve was limited. And also the type of the devices we had at that time was only an NT, I think an NTW. We didn't have the XT and XTW. So yeah, maybe at this time I will go for TEER, but at that time I would agree I wouldn't go for.
So, sounds good. Yes, David.
Yeah, I think it's a very interesting case, particularly now that this is CE marked. If we put things into perspective, we have to really look at the timeline. 2018 is not 2025. And when you look implanting a valve in the mitral position is only, at least in Europe and certainly in the United States, possible if you cannot do it any other way. So this is a very small percentage of all those cases. But I think the aim of the M3 is really one to overcome one of the limitations of the valves, namely to avoid left ventricular outflow obstruction. And that's happening with this particular device. And I think it is a fair statement that the TEER, looking at the images, would have been a challenge for the reason, you know, that the A2 or P2, depending, has a flail, and you know, at 18 we didn't have that much experience as today. Plus, we didn't have the newer generation of valves. So I think it is a very reasonable approach with an interesting, hopefully interesting and good outcomes.
Additionally, I think there was a deep cleft, and also that will also limit the outcome of the TEER, as we said specifically in that time, because we had the deep cleft at that time was a complete, I mean, a red flag for not to go.
So we can move on to Anas. I mean, with Dr. Ali, we said we're not going to go much of technicality, but he showed us some of the animation. So how it's going to be looking in the echo, if you can show us some
Sure.
of them.
Can everyone hear me? Well, okay, excellent. With this kind of procedure, what you're setting yourself up for is essentially you're trying to make it almost like a valve and ring situation. So you have the dock, and then you have the M3 valve. And the M3 valve is identical to the Sapien 29, except that it has this outer skirt. Okay. So what we typically do with this procedure is that we puncture the atrial septum, slightly posterior, slightly inferior. We're going to cover the interatrial septal puncture at a later point of the talk. And then once the dock is introduced, once the dock is introduced, what you're trying to do is that you want to guide it towards the medial commissure of the valve. So if this is sort of your mitral valve, you are guiding the dock towards the medial commissure. And this is part of the screening process by echo for this particular procedure, is that you want to have almost nothing sort of in the medial commissure like calcification or fusion, anything that would interfere with introduction of the catheter into the LV through the medial commissure. Once the the dock is introduced, and this is an echo. On the left side, we see the long axis view, and this is a bit different from a mitral clip where you start off with a bicommissural view. Here we have a long axis view, so 180, 120, 150. And on the right side, you have the bicommissural view. You can see here above the valve, you can see the dock. But you can also see that we've actually introduced the dock into the medial commissure because you see the white dot over here. The next step would be, for the interventionalist, would be to actually create the first turn so that you're surrounding the subvalvular apparatus. And you've seen that in the animation. So you would have the subvalvular apparatus like this, and the dock would basically encapsulate it or capture it. So as you can see, once the interventionalist completes the first turn, you can see that on both sides, outside of the subvalvular apparatus, you can appreciate that the first turn is complete. And my role as an echocardiographer is to always check that LVOT, because that first turn is usually the largest, and the catheter tends to want to go into the LVOT. So part of my assistance during the procedure is to make sure that they clear that LVOT and they continue around the mitral valve subvalvular apparatus. This is a sort of, this is a fluoroscopic view. Just going to try to play this. So you can see on the top video is your first turn being done and complete.
So I can ask here, Dr. Anas and Ali.
Yeah.
So we can see it's like basically the delivery system is very similar to the Sapien one that we're using for the TAVR. Is that correct?
That's pretty much correct.
And it's basically, it's an Edward valve, like the one, tri-leaflet that I'm going to implant. And you just see the turning, and this is what more fluoroscopy, you go with it, and then you proceed with your case, putting the dot, and then delivering the valve. Is that correct?
That's pretty much
So-
correct, Dr. Sundus.
So we can move on with your presentation. Can we have the presentation up again?
So I think what you want to do is you want to encircle the valves leaflet with this dock, and that works as an anchor for your Sapien valve. So I'm just going to go next and show some of the
So let's
procedural
have the presentation up.
fluoroscopic images at the time back in 2018. You can see the valve on the left is being deployed under rapid pacing. Very, very stable deployment, and in the middle you see an LV-gram showing really no residual mitral regurgitation post-TMVR with the SM3 valve. On the right, you see a still fluoroscopic image of how the valve looks like with the dock at the time. So that was back in 2018. Now, post-procedural TEE, you basically see a well-seated transcatheter heart valve in the mitral position. The gradient at the time was only 3 millimeter per mercury. What I want to highlight is there is also two very small paravalvular jets at 2 o'clock and 4 o'clock. That will become clinically relevant as we progress with the case. At that time, back in 2018, that was thought to be a very, very good result. So this is just the first in human experience of the TMVR with the SM3 published by the group in Vancouver led by Dr. John Webb. And they believe this patient was part of this 10 patients pilot study that was published in JACC Intervention. You can see back in 2018 or 2019, they achieved technical success in 90% of cases. So very, very doable procedure. 30-day mortality was 0%. Rate of stroke at 30-day was 0%. And the median hospital of stay was 1.5 days. Post-TMVR, there was a great reduction in severity of mitral regurgitation at 30 days, as well as significant improvement in the NYH symptoms as displayed here. So 5 years later, I was able to see this patient in clinic, and she presented back in 2023 with worsening shortness of breath and heart failure symptoms, which basically triggered all of those images 5 years post-TMVR.
Okay,
You
Dr.
can
Ali,
see-
here we have like the esteemed panelist of imagers with me. So I would like to direct the question to Dr. Ahmed and Dr. Goufi. Okay, so what are we seeing, Dr. Ahmed, here for those? And then Anas will take the mic after them.
Yeah, thank you, Dr. Sanders. So I think that's clear, and maybe it's just easier to see it in the 3D echo, where you can see there's a big gap there and there's a large paravalvular leak, which is the same area where the two small jets that we saw at the earlier echo immediately after the valve implantation. It looks like this area is like they join together and the gap becomes bigger and there is paravalvular leak. Again, I mean, is this like there's infection or something going on now, new thing, or this is just part of the, dehiscence of this, let's say, foam drain, which is around
so
the valve.
there is a
Yeah.
paravalvular leak.
Yeah.
Dr. Goufi, what is your take on that? Like and also you,
Yeah, so I'm not an echocardiographer, but I
but
just...
you're a plugger.
Yeah, absolutely. So thinking about the mechanism of how this valve anchor, again, no experience with this valve. And if this patient really, the primary mechanism for the MR was partly a functional with LV dysfunction, if the LV and the LV function drop with time, I would suspect the anchoring mechanism actually also can fail. Now, plugging this at this time, whether it's feasible or not, probably feasible, but the question we have to ask ourselves, in a couple of years now, is the LV going to dilate and the annulus is going to dilate and we're going to have more MR? I think it's going to come back to a discussion for any MR technology when we come to comparing ourselves to the surgeon. because this is absolutely beautiful technology, but over the years we can see that the paravalvular leak got worse,
So-
probably because the mechanism.
Those are
We have a
excellent
surgeon with
points.
us here. So Dr. Makhdoom, so 5 years ago, she was not surgical, high risk. Now I come to you and she's in her 80s. What are you going to tell me? Go away.
I call Dr. Faisal.
It's called Dr. Faisal.
But I think, I don't know, Dr. Ali, if you agree with me, but I think this is at the commissure side of the valve, right? So it's
Yeah, because, yeah.
probably, it's probably even if it was presence at the beginning of the case, sorry, at the immediate
Post,
post of
yeah.
echo,
There were two.
it's something that just got bigger maybe when the LV improved. And maybe it's technical, I'm not an expert in this, but this
So
is
we have
the
two things to
commissure, so-
discuss, like the etiology or the mechanism of this of happening and how to fix it and how to prevent it, I think. You want to take it from there,
No,
Dr. Ali?
just a comment. This is a very good point. That is it a real paravalvular or it's valvular from the native valve because it's coming from the commissure.
Yeah, so is it between the coil and the prosthesis or outside the coil?
Okay, so Ali, take it from there.
Okay, so that case was reviewed extensively by experts in the field as well as engineers from Edwards, and the valve function was thought to be normal at 5 years. You can see there's really no leaflet thickening, no leaflet calcification. The effective orifice area remained very large, and the mean gradient across the valve was only 4 millimeter per mercury. So despite the paravalvular leak, the valve function at 5 years appeared normal. Now the patient was brought back to the cath lab and were able to plug it with an VP2 8 by 7 millimeters. On the left side you see a nice fluoroscopic image of how the plug looks like in relation to the SM3 valve, and on the right hand side you see a very nice 3D reconstruction looking at the in-fos view where the plug is in relation to the valve itself.
So, Dr. Ali, the size or the choice, I mean, we have many pluggers in the room, apparently, Dr. Goofy and Dr. Bender also. I would like to ask Dr. Bender, would you have used an vascular plug 2? And then I'm going to look at my imager. And Dr. Anas, what do you think the best modality to measure the diameters or the axis? So we start with Bender and then you.
So as you see here, the paravalvular leak is mainly medial, which is a little bit tricky in with the transeptal puncture to approaching the medial jet, but still I think it is doable. And as you see, it is away from the valve. So still I think the paravalvular leak is a choice here because we're not free with the valve. So its valve is very away. So, and also the shape of the paravalvular leak, it is a circular. So, and also it is between high pressure with the LV and also the LA. So the first choice for me actually is the PDA closure device. I think it will be a good choice since it is like a disc from the LV side, and you will not compromise also the valve, although it is not a problem here. And also, I think also maybe Dr. Husain Advances, he's also experienced, he preferred the ASD, and I did with him a couple of cases. Really, it's a good choice. So I think maybe also the ASD device is a choice. And also AVP2, I think it will do the job. But really, the most common plug which we are using in the paravalvular leak, in the surgical paravalvular leak, is AVP3, which is mainly, it is a concentric, which can take the shape. I will not prefer it here, because here it is circular, so I will go with AVP2 or PDA or ASD.
So Anas, if like now Bender and Dr. Ali and Dr. Goofy is asking you, give me a size, give me something to work on, what is your methodology of checking the size? Mike, please.
So as part of my echo screening, I do use, both 2D and MPR imaging to try to get the best size, but occasionally this becomes very challenging, especially if there's a lot of metal, close to the site of the PVL, like there's not a good, cuff. In these cases, often CT is also quite helpful. So I use both actually, echo with MPR as well as CT to get the most accurate measurement I can get for a patient before closure.
Any thoughts, Dr. Goofy? Or
I think it's very important when you are planning a plug case is to ask yourself where is the plug going to anchor, in the ventricular side and the atrial side. The difficulty in this case is, for me, the operator used the coils to plug, the ventricular side in the coil part of the valve. Like when we are closing, for example, a mitral paravalvular or an aortic paravalvular, one side of the disc in the ventricular side and the other side in the aortic or the mitral side. For those, I think AVP3, AVP2 is actually as my reach to devices.
Okay, Dr. Ali, you can continue.
Okay, so this is basically the post PVL closure TE. You can see there's a great reduction of the paravalvular leak. There's only trivial residual leak. The valve looks pretty good. There's really no intravalvular regurgitation. There's really no gradient, and the valve function otherwise appears normal. So there has been some questions with regards to the mechanism of paravalvular leak. In this case, there are different hypotheses. I have to say nothing is super solid, but what we thought could happen is because of mechanical stresses on the native leaflet attachments that may lead to leak, progression of native, not biprosthetic native leaflet degeneration. But there's also this very interesting hypothesis looking at reverse annular remodeling after TMVR, which may result in localized leaflet prolapse. And this was well proven when we looked at this patient's CT scan back in 2017. You can see that the left ventricular end systolic diameter was 43 post TMVR. The left ventricle decrease in size, so the systolic diameter decreased to 38, but there is also significant improvement in LV function after TMVR. So does that count for reverse annular remodeling, which may result in a native paravalvular leak or leaflet prolapse? Don't really know, but this is a hypothesis that is worth looking at. So the patient we talked about today received the first iteration of the SAPIEN M3 valve. And in that first iteration of the valve, there was no PVL guard. Now, the current iteration of the valve has a PVL guard, and this is the valve that was deployed for patients in the ENCIRCLE trial, which completed enrollment, and the impression is result will be presented later this year. So this is a second or third iteration of the valve that currently has a PVL guard at the medial aspect of the valve, exactly where the leak was originating in our patient.
So we can have Dr. Anas to show us the guard that we were talking about. Can we have the smart screen on the table?
All right. So as Dr. Ali has mentioned, this has been a recurrent case with the M3 valve with the localized medial commissure PVL. So the design has since been revised, and you can see that there is a nitinol PVL guard that's now standard as part of the design of the valve in this latest iteration. This has no longer become a recurrent issue with this valve. And the theories as to what has caused this is there are multiple, but the most probably plausible theory is that with the reverse remodeling of the valve, you might get some, prolapse in the medial side of the valve, which results in the PVL. But this is what the doc would look like with the latest generation, and again with a significant drop in the rate of PVL since that initial edition of the valve. Yeah.
Thank you, Dr. Anas.
Yeah.
So we can conclude the talk by having your take-home message and then a final run on the panelists.
Sounds good. So to summarize, this is the first long-term follow-up report of TMVR that shows that the SM3 valve had a normal leaflet function at 5 years with no sign of degeneration. The current iteration of the SM3 valve being implanted in the ENCIRCLE trial has a PVL guard to mitigate procedural PVL in this location, and PVL following SM3 implant can be successfully treated with a transcatheter approach. You can refer to the full paper in JACC Intervention, which was published around 18 months ago. And this is basically to show that this is the first TMVR system that receives CE mark, and hopefully we'll have it available in our region as soon as possible. Thank you so much for listening, and happy to take any comments.
Thank you, Dr. Ali. So we are open to questions from the audience. We have 5 minutes to go. I will start with Dr. Makhdoom. Your thoughts, as a conclusion for this first case.
I think this is an amazing technology. We've been waiting for this for a long time. Since I started in the field of the structural heart intervention, everyone was saying, wait for the mitral, wait for the mitral, wait for the mitral. We waited too long, I think. But I think finally we're seeing some light, and I'm very excited to have it here and maybe have some.
Shortly, we're going to get it,
Yeah.
yes. Dr. Ahmed?
Congratulations, Ali. That was a great case. I think last week as well, they did first in the human M3. Like this is, I think, investigational. The other one was like in a regular setting. I think a couple of weeks ago or something like this. So my question is, like, you did the case long time ago, great results, and 1.5 day stay, like 0 stroke, 0 mortality. What keeps this technology so long to evolve and be in the markets? You know, it's comparable to our TAVR results. It's comparable to a mitral clip. Why it's still very shy and not in the market?
So this is a great question, Dr. Ahmed. I think, you know, when we talk about great results, just keep in mind that was only 10 patients that was presented back in the first in human trial. So that one part, and there's also a selection bias. Those patients were selected very carefully to achieve a good result. Now, the ENCIRCLE trial is wider population. I guess we cannot really say much until we hear the results, hopefully later this year. The other problem with any TMVR device, there is a proportion of patients who will fail screening due to anatomic or other reasons. So screening failure is a major problem with all the TMVR platforms. I guess that would be my answer.
Okay, great.
If I may add, I think also procedure complexity as well is a major factor compared to TAVR. Right? It's especially with this platform, I think the learning experience will be a little bit more steep.
Yeah, Dr. Ahmed.
So a comment and a question. So regarding the comment, I think we are seeing any valve which is inserted by like a catheter based, like the valve leaks a problem, and I'm happy that there are solutions for these things. My question is, this is a complex procedure, and there is nothing like anatomical, let's say, annulus that will hold this coil, let's say. So which valve is the best for these cases? Which mitral valve disease is the best for these cases at this stage now?
So I guess we only have one valve that's approved so far, which is the SAPIEN M3 valve.
I think he's asking about the etiology of the MR, like if there is like a preferable MR reason to go with. I think it goes the same like any simple tier. Stay away from significant calcification, have a good LVOT, don't fail the screen. If maybe Ali has other thoughts, I think it's the basic, same like in dying. What do you think?
Yeah, I think screen failure is a major problem for this platform and other platforms. Now, I know that for the ENCIRCLE trial, there is a 100 patients group that had valve in MAC using the SM3 valve. That would add more in terms of whether MAC patients would benefit from TMVR or not using this platform. I think there's a lot of unknown at that point until we hear more about the results.
Okay.
Can I ask a question to Dr. Ali? Along with the same subject that Dr. was discussed now about the pathology. Since you're involved in this technology, do you think that the amount of tissue in the mitral valve leaflet will dictate the outcome? In the surgical population, we always talk about the amount of tissue when repairing a mitral valve, repairing a myxomatous mitral valve. There's a wide spectrum of this disease has a wide spectrum. Some patients will have very minimal tissue, the repair will be easy, but those patients that we label them as Barlow's valve with bileaflet prolapse, they have plenty of tissue. The annulus is going to be small, but the mitral valve tissue is very generous. Do you think this will affect the technology?
That's certainly a very good question. Now, from my limited experience on this platform, we were not routinely measuring leaflet size or length. We were more interested in leaflet morphology, whether there's any abnormality or calcification, but certainly that's a very valid point.
If I may add, what's nice about this valve is that it can treat a lot of pathology. I know that there are cases that were treated that were functional, but also primary, including Barlow's disease. The main thing about this particular valve is that you want that medial commissure to be relatively clear so that you can guide a catheter below the mitral valve through the medial commissure. That would be the main thing that would interfere with deploying the valve. So as long as you pass the screening, there's no risk for LVOT obstruction or otherwise, you can deploy the valve as long as that medial commissure is clear. So there's multiple pathologies that can be used for this valve that can be used in that situation. Even patients who have had a ring. There's a couple of cases that I know where there is a surgical ring that's already been implanted. You can use this valve in those patients as well.
And the final notes from Dr. Faisal Al-Goufi as we're transitioning to Dr. Bandar Al-Shehri.
I think, again, the mitral alley is expanding a lot, but I have to document that our learning curve in the mitral has lagged behind in the TAVI due to the complexity of the mitral valve. And to be fair, also to have to compete with a very solid outcome for mitral valve repair. So I think we are definitely in the right track, but it's going to take a bit of time to reach that stage.
Thank you, Dr. Faisal. Thank you, Dr.
Thank you
Ali.
so much.
For a round of applause, please. Thank you, Dr. Ali.